Now we're going to see the liver cirrhosis. Cirrhosis is a irreversible fibrosis of the liver due to tumor growth factor beta secretion from the stellate cells that are beneath the endothelial cells that line the sinusoids of the liver. This results in fibrosis bands and degenerative or regenerative nodules. This could be micronodular form, macronodular form, or mixed. Micronodular is when we have nodules less than 3 centimeters and uniformly in size, and macronodular are larger than 3 centimeters, and these are at much more increased risk of hepatocellular carcinoma development, and this further can lead to necrosis, etc. And mixed is the macromicronodular form. Cirrhosis could be due to intrahepatic or extrahepatic etiologies. Intrahepatic includes hepatitis B virus and C virus, alcoholic liver disease, non-alcoholic fatty liver, autoimmune hepatitis, hemochromatosis, Wilson disease, alpha-1 antitrypsin deficiency. And the extrahepatic includes congestive heart failure, Budd-Chiari syndrome, and extrahepatic biliary atresia. Now, the diagnosis. First, the best initial test is to measure the synthetic ability or function test of the liver. This includes to measure albumin, transaminase, bilirubins, and the albumin will be low, bilirubin will be high, transaminases could be high. Clot factors will be decreased, so this means an increase in the PT. And the increase in the PT is the most significant factor to tell us the prognosis. Additionally, the diagnosis could be confirmed with biopsy. And in the biopsy, we will see these fibrotic bands and regenerative nodules. Now, the presentation could be asymptomatic, could be abdominal tenderness, right upper quadrant pain, and all the manifestations of cirrhosis include purpura, spider angioma, palmar erythema. This is the palmar erythema is due to the decreased metabolism of estrogen by the liver and leads to vasodilation, and the purpura is due to thrombocytopenia. Additionally, the patient can have fetor hepaticus. This is due to mercaptans. The patient can have problems with the bone marrow, like anemia, metabolic issues, hepatorenal syndrome, cardiopathy, a lot of things. Now, the portal hypertension, this is developed because here we have the liver, here is the portal vein, the liver is damaged, so the pressure increases backward. So here is the portal hypertension. And remember that the portal hypertension is going to produce 3 things. Let me put the communication between the portal system and the systemic system. So we have 3 places. On the esophagus, the the umbilicus, and the rectum. So the development here could produce esophageal varices. Here caput medusa and hemorrhoids. So here I will put the vein that is coming from the portal vein, and here the systemic vein that is going to drain to the vena cava. So here we have the left gastric, and here the esophageal veins that drain to the acidus vein. Here we have the paraumbilical veins and the veins of the anterior abdominal wall. Here we have the superior rectal vein and the medial rectal vein. This drains from the superior rectal vein to the inferior mesenteric vein, then to the splenic vein, and then to the portal vein. And here the medial rectal vein drains, could be to the inferior rectal vein or directly to the pudendal vein, and then the internal iliac vein, and then the common iliac vein, and then the inferior vena cava. So these are the communications that we have between the portal vein and this cava, this circulation vein. So if we have increase on the portal pressure, so there is portal hypertension, we will have hypertension on these veins, and they will pass to the other side. So here we have the development of varices, caput medusa, and hemorrhoids. And remember that esophageal varices, bleeding can arise from this. So every patient with cirrhosis or esophageal varices needs prophylaxis with propranolol. In case of bleeding, remember we need to put 2 IV port lines, nasogastric tube, octreotide, and prophylaxis for spontaneous bacterial peritonitis that includes ceftriaxone or ciprofloxacin. The treatment could be with TIPS. This is transjugular intrahepatic portosystemic shunt. Both this increases the risk of hepatic encephalopathy. This is due to decreased metabolism of NH3. So there will be this toxic circulation around all the neurons and the astrocytes. So there will be edema, and this hepatic encephalopathy presents with asterexis. We will ask the patient to extend my hands, and we will see this flapping. Or sometimes, if it is very subtle, we can do this to the patient, and then we will see the flapping. The hepatic encephalopathy can be further, we can worsen it, or we can disencadenate it if we give something like furosemide, because furosemide can produce hypokalemia, volume depletion, and metabolic alkalosis. All this leads to increase in the hepatic encephalopathy. The treatment with hepatic encephalopathy is mostly with lactulose. We want to produce 2 to 4 stools, or the rifaximin. Rifaximin is an antibiotic for bacteria that are all the time producing this NH3. And we don't use neomycin because neomycin has a lot of renal troubles. Alright, now this is hepatic encephalopathy. Now, the other presentation will include the ascites. So, ascites in a patient with cirrhosis, we don't know why the patient has ascites, if it is secondary to a infection or secondary to just cirrhosis. So the ascites diagnosis or analysis is with the serum albumin ascites gradient, or serum ascites albumin gradient. This is, we will take the albumin concentration of the serum, and we will subtract the albumin concentration on the ascites fluid. So we will take paracentesis. We need to take ascites in every new, we need to take paracentesis in every new ascites. So we would have that this gradient is above 1.1 or below 1.1. If it is any one of these, then we can further divide into the protein concentration of the ascitic fluid. If it is above 2.5 grams per deciliter or below below or greater than 2.5 grams per deciliter. So if the serum ascites albumin gradient is above 1.1 and the protein is less than 2.5 grams per deciliter, this is cirrhosis. If it is above 2.5, then this could be Budd-Chiari syndrome, and in which case we will need to test for the JAK2 kinase mutation. These are the portal hypertension. If we have a serum acetic albumin gradient less than 1.1 and protein less than 2.5, this could be nephrotic syndrome. And if it is above 2.5, this includes tuberculosis, carcinomatosis, a lot of things, in which case we could do biopsy. So this helps us to distinguish the etiology of the ascites in this cirrhotic patient. Now, a sudden change on a cirrhotic patient, we should think in hepatitis A virus, hepatic adenoma or hepatoma, and the ascites. So now every patient with cirrhosis requires the vaccination against the hepatitis A virus, hepatitis B virus, and the strep pneumo 23 valent vaccine, the PCPV 23. So how will we treat the cirrhosis? We already saw how to treat the encephalopathy. The esophageal varices will be treated as a upper gastrointestinal bleeding focused to the esophageal varices, and the cirrhotic, all this matter of cirrhotic is treated with spironolactone, because spironolactone is a small diuretic, weak diuretic, but prevents the loss of potassium. So increases the potassium. Now we can give furosemide to decrease the ascites and all this edema that is there. We can give furosemide, but only after giving spironolactone, because if don't, we can disencadenate the hepatic encephalopathy. Now the patient has these ascites, and there is vasodilation of the splanchnic vasculature due to this portal hypertension, and all this leads to hypotension. So the patient can have hypotension. This will increase the renin angiotensin aldosterone system, and this leads to hypokalemia. Also, there will be increase in the antidiuretic hormone, and this patient present with hypervolemic hyponatremia, because even though the patient is overloaded, it's going out of the intravascular space. So the patient develops hypotension, orthostatic hypotension, etc. What else? If there is perforation of the diaphragm due to increase in the pressure because of the ascites, there will be fenestrations on the diaphragm, and this leads to hydrothorax, that is most commonly seen on the right side, and this is the ascitic fluid on the thoracic cavity. Additionally, for these ascites, remember that when there is ascites less than 1.1 and with proteins, low proteins, increased creatinine, hyponatremia, we need to give prophylaxis for spontaneous bacterial peritonitis. In this case, we will give this prophylaxis with Bactrim, ciprofloxacin, or norfloxacin. And remember that also for esophageal varices bleeding, we are giving the prophylaxis for spontaneous bacterial peritonitis, but in this case is with ceftriaxone or ciprofloxacin. And if the patient already had the esophageal varices bleeding, and now we want to prevent another esophageal variceal bleeding, yes, we will give propranolol, band ligation, but also we want to prevent the spontaneous bacterial peritonitis, so we are giving that. And if this patient develops spontaneous bacterial peritonitis, we need to give prophylaxis long-term life for another episode of spontaneous bacterial peritonitis. Spontaneous bacterial peritonitis is treated with ciprofloxacin or ceftriaxone, and in this case of the previous spontaneous bacterial peritonitis episode, now the prophylaxis after the treatment, now the prophylaxis would be with ciprofloxacin, norfloxacin, or trimethoprim sulfamethoxazole. So these are all the complications that can arise on the patient with cirrhosis.